The United States remains the only major developed economy on the planet that doesn't guarantee healthcare to all its citizens as a right of citizenship, a distinction that places it in a small and shrinking group of global holdouts. While we often hear about the wonders of modern medicine, the actual mechanics of how people pay for it, or fail to, reveals a stark divide between nations that treat health as a public utility and those that view it as a market-driven commodity. In the US, roughly 27 million people, or about 8% of the population, were uninsured as of 2024, a figure that's actually an improvement from a decade ago but still leaves millions vulnerable to the kind of medical debt that is virtually unheard of in other wealthy nations.
It's a really sharp contrast when you look at the OECD, which is essentially the club of the world's most developed nations. Out of those 38 countries, the US is the outlier. Every other member, from Germany and Japan to even newer members like Mexico and Colombia, has some form of universal or near universal system. Now, that doesn't mean they're all socialized medicine in the way people often use that term. There's a spectrum. You have single-payer systems like Canada's, where the government is the only insurer, and you have multi-payer systems like Germany's or Switzerland's, which use private insurers but mandate coverage for everyone. The US model is essentially a fragmented patchwork where your access to care is determined primarily by your employer or your income bracket, rather than just being a member of society.
And that fragmentation is incredibly expensive. We're spending nearly twice as much per person on healthcare compared to peer nations, about $14,885 per capita in the US versus an average of roughly $7,300 in other wealthy OECD countries. You'd think that for double the price, we'd be seeing double the health, but the data from groups like the Commonwealth Fund suggests the opposite. We rank last among high-income countries in life expectancy, maternal mortality, and infant health. It's a paradox where the most expensive system in the world often produces some of the worst long-term outcomes for its population.
The price tag isn't even driven by people using more care. Data from the Peterson KFF Health System Tracker shows that Americans actually have fewer doctor visits and shorter hospital stays than people in Germany or Japan. The cost is driven by the sheer price of services, things like an MRI or a day in a hospital bed, and massive administrative overhead. Because the US has hundreds of different insurance plans, all with different rules, billing, and negotiations, we spend over $1,000 per person just on administration. In countries with universal systems, that money goes toward actual medicine because the billing is standardized.
If we look outside the developed world, the landscape changes. Universal healthcare isn't just a wealthy country thing anymore, but there are still major nations struggling to get there. Take Nigeria, for example. It's the most populous country in Africa, yet its health insurance penetration is startlingly low. Only about 5 to 10% of the population is covered. For the vast majority of Nigerians, getting sick means paying out of pocket, which the World Health Organization notes can be catastrophic for families living near the poverty line.
Nigeria is an interesting case because they are trying to change this. They recently passed the National Health Insurance Authority Act to try and make insurance mandatory, but the structural hurdles are massive. You're dealing with a large informal economy where people don't have steady paychecks to deduct premiums from, and a public health sector where, according to a 2024 WHO assessment, about 70% of primary health centers are non-functional or operating below standard. It's one thing to pass a law saying everyone should have insurance. It's another to build the hospitals and find the 150,000 extra doctors the Nigerian Medical Association says they need just to meet basic demand.
Pakistan faces a similar uphill battle. They've launched programs like the Sahat Sahulat program, which provides inpatient coverage for the most vulnerable, but it's still far from a universal entitlement. Most healthcare there is still a private expense at the point of care. It's a reminder that universal healthcare isn't just about the insurance part, it's about the universal part, ensuring that the poorest person in a rural village has the same right to a bed as someone in the capital.
Exactly. And then you have a country like India, which is attempting one of the most ambitious healthcare experiments in history. They launched Ayushman Bharat in 2018, which is often called the world's largest health assurance scheme. It aims to cover the bottom 40% of the population. That's roughly 550 million people. Data from India's 2024-25 economic survey shows that out-of-pocket spending has dropped from 62% of total health costs down to about 39% since the program started. That's a massive shift in a short time.
But is India universal yet? If you're in the middle class in India, you're often stuck in a coverage gap. You're not poor enough for the government scheme, but private insurance is expensive. And even for those covered, the system mostly handles hospitalizations, not the day-to-day costs of medicines and diagnostic tests, which still eat up a huge chunk of household budgets. It's a step toward universal coverage, but it highlights how hard it is to provide full protection in a country of 1.4 billion people.
China is probably the best example of a country that has almost solved the enrollment problem, but is still working on the universal problem. They've managed to get about 95% of their population into some form of public health insurance scheme. That's an incredible achievement given that 20 years ago, coverage was around 10%. But even with 95% enrollment, Chinese citizens still face significant copays. For a major illness, the insurance might only cover 50% or 60% of the cost. So while you technically have healthcare, a cancer diagnosis can still bankrupt a family. This is why many experts argue China hasn't quite reached the universal finish line yet. True universal coverage means you don't face financial hardship when you get sick.
It's interesting to look at the why behind these differences. Why did Europe go one way and the US another? Historians often point back to the late 1800s. Germany was the first to implement national health insurance under Otto von Bismarck in 1883. The motivation wasn't purely altruistic. It was a political move to prevent social unrest and keep workers healthy for the industrial machine. In Europe, healthcare became a tool for national stability. In the US, we didn't have that same level of labor pressure at the time. And by the time we started talking about it seriously in the mid-20th century, the private insurance industry was already so entrenched that it became almost impossible to uproot.
And that entrenchment creates a different kind of inertia. In the US, the debate often gets framed around choice and innovation. Pharmaceutical companies argue that high prices are necessary to fund the R&D for the next miracle drug. But when you look at the reality for patients, that choice is often an illusion. If your employer chooses your plan, you don't really have a choice. And the innovation argument is hard to swallow for the 25% of Americans who say they struggle to afford their prescriptions. We have the best medical technology in the world, but if 12% of the population has to borrow money, collectively $74 billion in a single year, to pay for it, who is that innovation really for?
South Africa is currently in the middle of a massive legal and political fight over this exact issue. They just signed the National Health Insurance Act into law in May 2024. It's meant to create a single government fund that buys care for everyone, effectively ending their two-tier system, where 16% of the people get world-class private care and the other 84% rely on overstretched public hospitals. But the private sector is fighting it tooth and nail, arguing it's unconstitutional and will bankrupt the country. It's a real-time case study in the friction that happens when a country tries to move from a market-based system to a universal one.
It's a 15-year rollout plan, and the challenges are daunting. Critics point to South Africa's high unemployment and narrow tax base, asking who is actually going to pay for it. But the government's argument is that the current inequality is even more expensive in the long run. When you have a massive part of your population that can't access preventative care, they end up in emergency rooms with advanced illnesses that are much harder and more expensive to treat. That's a universal truth, whether you're in Johannesburg or Chicago.
The human cost of the no universal system model is best seen in medical debt. In the US, medical bills are the leading cause of bankruptcy. Even for those with insurance, high deductibles can mean a $5,000 bill for an ER visit. A Gallup poll from early 2025 found that nearly 1 in 10 Americans owe more than $250 in medical debt. And for many, that debt lingers for years, trashing their credit and preventing them from buying homes or starting businesses. It's a drag on the entire economy, not just the individuals.
That's why the access versus coverage distinction is so important. You can have a card in your wallet that says insurance, but if you can't afford the $50 copay to see a specialist, you don't really have access. This is the hurdle India and China are facing now. They've checked the box for coverage, getting people on the rolls, but now they have to figure out how to make that coverage deep enough to actually protect people from financial ruin. The US hasn't even fully checked the first box yet.
It feels like we're watching a global realignment. More countries are realizing that healthcare is less like a luxury car and more like a road system, something the government has to maintain for the whole thing to work. Even if the US stays an outlier for now, the pressure is mounting from every side. When you see a country like Rwanda, which is much less wealthy than the US, successfully providing health insurance to over 90% of its citizens and seeing massive gains in life expectancy as a result, the "we can't afford it" argument starts to lose its teeth.
It really comes down to what a society values and how it defines efficiency. If efficiency means the highest possible profits for insurance companies and hospitals, the US model is doing its job. But if efficiency means the most health for the most people at the lowest cost, then the universal models we see across the rest of the developed world are clearly winning. The major countries without it today, the US, Nigeria, Pakistan, all have their own unique historical and economic reasons for where they are, but they are increasingly standing on an island as the rest of the world move toward the idea that nobody should go broke just because they got sick.
Ultimately, the global trend is moving toward the recognition that health is a foundational requirement for a functioning economy. Whether it's through the slow expansion of insurance in China or the radical restructuring being attempted in South Africa, the goal is the same: removing the price tag from the doctor's office door. It's a complicated, expensive, and deeply political journey, but for most of the world, it's a journey that has already reached its destination. This conversation is a great one to share with anyone who thinks the current healthcare status quo is the only way to run a country.